Hey guys, welcome back to the Altmed podcast. Andrew Dowling here. If you are getting something out of listening to these podcasts, which we hope you are, please remember to hit like and subscribe. Alrighty, today's episode. So Mitch Kurtz is with me as always, my co-host. And
Howdy.
G'day, Mitch.
Hello.
Looking groomed, actually.
Yeah, for the first time ever.
And we are delighted to have on the show today Dr. Laurence Kemp. Dr. Kemp is head of medical at Cann I Help in Brisbane and is a GP. Great to have you with us, Laurence.
Well, thanks very much for having me.
Excellent.
Absolute pleasure. I think as always, we will start with a little bit on your background and how you found yourself meandering into the cannabis space. Like so many doctors are starting to move over. So we'd love to just get a little bit on your history to date.
Yeah, sure. So I'm a GP by background. I trained in the UK and I worked there as a GP for about 10 years or so. I moved over to Brisbane along with my family in 2018. And I think the kind of interesting thing was that the UK medicinal cannabis industry is a long way behind Australia. So, at the time I left, I think there were literally just one or two patients in the entire United Kingdom who'd been approved to use medical cannabis products. And those were extremely specialist indications. So because a GP, basically, I'd had no exposure to this whatsoever when I came over to Australia. I think what I noticed that within a few months of I set up in a GP clinic in Brisbane suburb, began to build up a base of patients, and obviously, like most general practitioners, you have your share of patients with long-standing chronic pain problems, with long-standing mental health problems. That stuff's very kind of core bread and butter of general practice. And after a while, some of my patients started to ask, what I knew about medical cannabis, what my views were on it, and whether it was something I thought they might benefit from. To begin with, I was honest with patients and said, look, I don't know very much about this. It's not something I've had a lot of experience in from my training in the UK. It's not something I know enough to prescribe for you, but I'm very happy to refer you on to somebody that does. So the first few patients I referred out to other cannabis clinics. And I think what struck me was that the patients came back, and a lot of them, we saw really marked improvements with the therapy that they're on. Their pain had got better. They started to go out more. Their mobility had improved. And I thought, as a doctor, I thought this is just something I've got to learn about. This is a therapy that really seems to be working for some of these patients. And so I set about thinking, well, I don't want to refer my patients anymore. I want to upskill myself. So, I do what doctors do. I went on some courses. I did a bit of reading. I did some research myself, talked to some of the cannabis companies out there, and then, started making my first tentative steps into prescribing these medications myself. I think that this was 2 and a bit years ago, and I think that the thing that I found going into this space was that word quickly gets out, and before I knew it, I had a stream of patients coming to see me to access or to discuss medical cannabis therapy, and really things took off in quite a major way, and I got a couple of other colleagues within my practice who were interested, and we built a little bit of a clinic. And then at the start of this year, we kind of formally founded Cann I Help as a specialist medical cannabis clinic. So for me, it's been 2 and a bit years I've been doing this. I've treated well over 1,000 patients now, and it's become quite a focus of what I do. But as I say, it was really something I fell into by accident. It was something that I had patients that asked me about it. I saw the improvement that they were experiencing, and as a doctor, it was something I was just keen to learn more about.
Yeah, amazing. I can imagine that maybe some of those first scripts were a bit daunting. We don't actually think very much about that first kind of the pathway to become a cannabis doctor. But that first script that you dished out with, is there a little bit of I don't know, like nerves or something like that?
Yeah, no, I think as a doctor, we use new medications all the time. You know, we go to medical school, we're taught and we gain experience with the drugs that exist at that time. But you know, new drugs come on the market the whole time, new therapeutic products. So I guess for me, it wasn't so much I was using a new medicine, because there's always a first time you use a new medicine, and you know, as a doctor, you just make sure you know enough about it to be using it safely and appropriately. I think the daunting element for me was, you know, about the bureaucracy around it. It was about needing to fill out the forms and apply to the TGA, and you know, and all of the additional kind of red tape that comes around using cannabis in Australia. And I think that was the thing that made it, you know, made it quite daunting as an initial prescription.
Yeah.
I think obviously to begin with, when you start off, you're very conservative in the approach you use, and you know, after you've treated a few hundreds or thousands of patients, you become far more familiar with the products, and you're happy to go in with larger doses initially for people, because you've just got a, you know, better understanding of the responses you're likely to see with things.
Yeah, and that's so true. And I think that bureaucracy gets handed down as well. The issues with that get handed down to the patients as well, and they really feel the effects of that. And I think it's something that's echoed all the time, and probably why you have that stream of patients is the access is just so difficult. How do you find, you know, obviously being in the industry for a while now, in Australian years, it's a bit like dog years in some respects. But after, you know, 2.5 years moving from, you know, I guess in the early days, probably far more bureaucracy than there is now. How do you find that access piece for the patients at the moment?
I think the access is improving. I think there are more and more doctors who are moving into this space and are happy to consider medical cannabis as a treatment. So I think things are definitely on the right track. I still think that, you know, a lot of doctors are put off by the additional you know, bureaucracy around these medications, and I think that's what we've tried to do at Cann I Help, is just develop really good systems for doctors and good support from nurses, so that we can take doctors that want to move into this space and can really support them through it, and take a lot of the weight off their shoulders in terms of managing all of the bureaucracy and things that come along with this type of medicine, unfortunately.
Yeah. So I've got just a query around, for those patients. I know that the TGA has a sort of a scheme, or the authorized prescriber pathway, but for most patients, particularly in those early days, but even still to this day, there's a lot of patients who will be the subject of a doctor submitting to the TGA on a per patient basis, an application under the special access scheme. So I'm just curious, you know, how often, sort of, maybe this is something that applied more in the early days, but did you get some of those applications knocked back? And because I imagine some of our audience who might be thinking about having that conversation with their doctor might be going, you know, or would I be eligible? Would I qualify? What kind of, what are some of the tricky parts for you in kind of providing the TGA with a clinical justification for having a patient prescribed cannabis?
Yeah, so personally, I've had very few, if any, of them knocked back. But I think that the reason for that is I undertake a pretty thorough screening of patients beforehand, and I won't even put an application in unless I'm pretty confident that we're going to get through that process. Within Cann I Help, we now have a number of nurses who assist doctors with these applications, and the training that I always give the nurses on how to prepare these are with the clinical justification. You know, you need to say what the issue is that you're treating, and you know, you need to identify an issue that patient has that will be amenable to treatment with cannabis. You then need to state why it's important. So just give some justification as to the impact it's having on that patient's life. You need to be able to demonstrate, you know, that they have tried some first-line therapies and why those therapies either haven't worked or haven't been well tolerated. And then you need to just provide quite a clear idea about the treatment plan that you're following with this patient, whether you're going to be treating them with a single product or multiple products in combination. So I think really it's about selecting the right group of patients, and I find that the vast majority, probably 80% of patients that do come and register with our clinic do qualify and do meet those criteria. but you've got to make sure that you're kind of ticking all the boxes there in order to to go through the process successfully.
So I've got a corollary to that is, would somebody's fear of side effects of a medicine be a sufficient basis for a clinical justification for cannabis? So for example, I suffer from pain. I might treat it with, lots of Panadol or something. Actually, hopefully not too much, because that's not good. But if I was, reading about the opioid problem that we seem to have in our society, and some of the really dangers, the dangers of those drugs to, say, respiratory systems and the like, what do you think about that as a basis for prescribing someone cannabis? Just that patient saying, I know I could be prescribed opioids, but I really don't want to be. I just want to actually trial cannabis. How does that go?
So look, I think there are some grey areas here, but certainly that's a route I've gone down with a few patients. I think with opiates, what we actually know from a lot of the studies that have been done with opiates is that opiates can be effective for acute short-term pain. We know that for people with long-term chronic pain problems, that opiates are generally not helpful. There are issues with developing tolerance. There's issues with developing dependence. So there's the side effect profile with opiates often isn't good as well. So I think you've on very reasonable grounds there as a doctor to say actually that we know that opiates are not going to be particularly useful as a therapy. And so that I certainly wouldn't insist that people had tried and failed on opiate therapy before we considered medical cannabis if we're treating long-term pain. I would be more keen if someone's got long-term back pain just to say, well, have they had a bit of physiotherapy? Have they tried some other therapeutic options before moving into it? But certainly use of opiates is not a prerequisite from my point of view, because all of the evidence says they don't actually work very well.
That's interesting that you that I haven't heard of it explained that way before. Would it be similar, or that approach rather, like not? It's usually what I hear, at least from doctors, is the opiates were causing side effects. But if you're saying that you can just kind of come through with seeing a physio or something, I find that very interesting as a first line therapy.
I think what the TGA want is that you can justify you're not using the medical cannabis as a first line therapy. So for someone that's been to see me and say, look, I've had a back pain for a number of months. I've tried some over-the-counter painkillers. Maybe I've had a bit of ibuprofen and some paracetamol. I've seen a physiotherapist. They've given me some exercises. I've tried doing that. Maybe they've even tried some acupuncture or something like that, and that isn't working. Then from my point of view, they've tried a number of therapies. They've tried a couple of licensed drugs for that indication. I certainly wouldn't be going down the line of insisting that they need to take. Need to trial codeine or tramadol or oxycodone or something like that, because all of the evidence points to the fact that those drugs are more likely to be harmful than beneficial. So it's a not to me insisting someone tries a drug that that we know there's very little evidence to support its use in those cases. So no, I absolutely don't insist on people having tried opiates. I find most of my patients have, but it's not something I would be insisting on.
It's not a prerequisite, is what you're saying.
Well, does it? No. Yeah. Does that sort of apply as well with things like, I'm just thinking benzos and
I was going to ask the same thing.
Well, yeah, great minds, Mitch. But I mean, because I'm just trying to think that sort of approach that you've suggested, where a first line therapy could be physical therapy. Is it the case that somebody could try, say, seeing a counselor or a psychologist as a first line therapy for coming in with depression and then being moved to medical cannabis? Sorry, I know there's a very, I just know that our audience be very interested in this, because I know pain, anxiety are some of the most frequently prescribed conditions with cannabis, as you'd know.
Yeah, no, absolutely. So I think for anxiety, for example, then certainly psychological therapy and cognitive behavioral therapy in particular is recognised as a first line treatment there. So I wouldn't insist on having tried benzodiazepines. Benzodiazepines aren't recommended in treatment of anxiety disorders. They again, similar to opiates with pain, they can give a short-term benefit, but in the long term, they're not particularly useful. So I think I would be looking for patients that have tried first-line therapies. So, either had some psychological therapy or usually have tried an SSRI medication. Or potentially, there may be good reasons why they don't want to try that. Maybe they've had side effects with using them in the past, or there are other medical conditions that they've got that make those medications, not appropriate for them to use. So I guess I think the key point is that I think a lot of clinicians think that cannabis has to be a last resort and you have to have tried everything. And that really isn't the case. It just means that you have to, you can't use it as a first line. So as long as the patients have tried something, so you're not using it, you're using it first line, then I think you can have a discussion with them about the potential benefits they might get from trying cannabis. Obviously, there's no guarantees, that it will work, but I have that open discussion with them about the risks and the benefits. But look, I think the basic point is you don't have to have tried, every single painkiller, every single antidepressant. We just have to be able to kind of justify that we're not rushing into using that as a first line.
So what about then? That brings me to an interesting point. What about patients that have tried cannabis before? Is that something that you see in the clinic? Do you see people that have come in who have already been exposed to cannabis use and said, I'd prefer to maybe try a medical product, or I've found relief, but I can't get it, or I'm not sure the different range of scenarios. But
I would say probably half of the patients that come to our clinic have got some history of cannabis usage. Either they've tried medical cannabis in the past, or they've used cannabis that they've obtained on the black market. I think I take that into account. If somebody with an anxiety issue or with a pain issue has tried some street cannabis and they found that it's worked really well for them, then in many ways that makes me more inclined to prescribe it, because we know that this is likely to be effective. So look, I often have these open conversations with patients about what they have used and build that into their treatment plans. And it actually affects what you do quite significantly. For patients that have got a history of using, maybe using a cannabis flower on a regular basis, with that kind of patient, they're unlikely to benefit in a major way from a low strength oil. You may have to start their treatment with something a little bit stronger. And also, I think one of the main challenges we see in people coming from the clinic having been using street cannabis is that often they don't know very much about where that's come from, what strain it is, what strength it is.
Yeah, correct.
And so sometimes they do, but often they don't. And so it can be a bit of a challenge kind of working out how much of a medical product to put them on. And look, generally I find that with a really high quality medical grade product, usually people can get by with about a quarter to a half of the amounts of street cannabis that they were using, just as a kind of rough rule of thumb I've found.
Yeah, that's very interesting, because, well, two things. People are always telling us, at least, they're kind of scared to go to their doctor because they fear, I don't want him to know that I'm using cannabis, even though that's what I want, because I don't want them to think I've been doing something illegal, if that makes sense. So it's interesting to hear that you have so many patients that are familiar with it. And then, I think that the other thing I'm very interested in is the kind of how you measure the improvements with cannabis, because that's something that's still kind of, we have clinical studies being conducted across the globe and the emerging literature around that. But as a GP on the front line, what are you seeing? How is that conducted? How do you get from point A to point B in a way that is somewhat quantifiable?
Yeah, no, absolutely. So, obviously we measure all the time in the questions that we ask the patients and get their subjective, views on, how much their sleep's improved, how much their pain's improved. I'm really someone that's quite a big fan of trying to objectively measure these things as much as possible. So we, Cann I Help, certainly, the process our patients follow is they register with our clinic, and then all of them have a kind of free, no obligation consultation with one of our nurses who goes through a lot of the background and assesses their eligibility. And our nurse then sends out a whole load of questionnaires for that patient to complete. So these are kind of standardized measures. There's questionnaires to measure pain, questionnaires for quality of life, sleep quality, anxiety and depression, that kind of thing. And then we repeat those questionnaires at regular intervals. So I think the benefits of that is it gives both the patient and the doctor some objective measures about how they're doing, and so we can see the effect that the medication's having on them. And it also provides us with some quite useful data as a clinic that we can assess the effectiveness of the treatments that we're using. So one of the things I often find with people not just using cannabis, but with using any medication, is that they kind of reset their baseline in their head. So you can have someone whose sleep is absolutely terrible to begin with, and then after 3 months their sleep's an awful lot better, but they still have a bad night before they speak to you, and you say, okay, how are you doing with the sleep? And they say, oh, it's not great, and then when you get them to do the questionnaire, you can say, well, actually, your score has fallen really quite dramatically since what you were on last time. So I think it's useful as a tool to help getting patients to reflect on how they're doing and tracking their progress. But yeah, we've got some quite interesting data on on how effective these treatments are in our patients.
We love data, so if there's anything you feel open to share, we would
look, I can certainly give you some little snippets of that. So I think one of the main things that we probably our biggest indication is chronic pain. So we use a score called the Pain Disability Index. So it's basically a questionnaire with 7 different areas, and each area is scored out of 10. So a score of 0 would be that there's no disability, 2 would be mild, 5 would be moderate, and 8 would be severe, and kind of 10 would be the worst possible. So the 7 domains are, family and home, recreation, social activity, occupation, sexual behavior, self-care, and life support activities. And so we get the patients to score in all of those. Look, what we see is, on average, our patients are scoring 43 out of 70 to begin with. So we're talking, in each of those different areas, they're scoring somewhere between 5.3 and 7.3 on average. So in all of those, we're on the kind of moderate to severe level of disability in patients at the start. What we see is, after 3 months of treatment, we've seen a reduction of about 13.5 points. So on average, kind of 2 points across all of those domains. So really quite significant. We're bringing people down from an average score where they're on the severe end to where they're kind of under moderate towards mild symptoms on average. So I think that's a really, really encouraging result. We see that the same thing or similar changes with stress, anxiety, and depression scores in patients that we're treating for mental health disturbance. We use a sleep questionnaire, and on average, our patients are scoring kind of moderate to severe to begin with, and after 3 months, they're scoring what we call sub-threshold. So below the threshold in which you clinically diagnose a sleep problem. And we use a WHO quality of life questionnaire, and basically we see in all domains of quality of life, whether we're looking at overall quality of life, satisfaction with health, life enjoyment, energy levels, we're seeing consistently an improvement in all of those areas after just 3 months of therapy. So it's really, really encouraging results from the point of view of our clinic.
Yeah, amazing. And I imagine kind of people getting several benefits at the one time across, not just isolated pain, but possibly pain and some sleep help, and also if they do have a little bit of anxiety that's wrapped up, and you probably have a multi-pronged kind of approach there.
Absolutely. And we know that physical health and mental health issues commonly coexist with each other and feed off each other. So the vast majority of patients with a chronic pain problem will have a degree of depression going on there. The vast majority of patients with severe anxiety will have a bit of a sleep disorder, and I think that's the nice thing about cannabis medicine, is it does often work across multiple domains there. So the results we've seen so far are really encouraging, and it's really satisfying for me as a clinician and as somebody that's running this organization, that I can see the impact it's having on individual patients day to day in clinic. But then to look at all of this aggregated data and see that, as a clinic as a whole, we've got several hundred people that are reporting better symptoms, better quality of life now than they were 3 months ago. I just, I think gives you a good feeling as a doctor, to be honest, to be able to, to measure and look at how you're helping people.
It's great. I had a thought as you were sort of talking through that someone playing devil's advocate might say, well, that data that you're getting is subjective, qualitative data. Is there any kind of objective, quantitative data? Do you have patients that are interested in, say, regularly getting blood tests or other kinds of tests that can show improvements to particular biomarkers, or what you might be looking for to measure it?
Yeah, look, I think you're right. We're using medicinal cannabis here for symptom management in most of these cases. There is no biomarker that can measure someone's pain response. There's no biomarker that can reliably measure someone's sleep. So yeah, look, I think if you're developing a drug for diabetes, you've got established biomarkers. But when you're looking at pain and anxiety and depression and stuff, actually questionnaires is the best way that you can access it. And I think the way that we score them is as quantitative and as reliable as we can. We didn't make up these questionnaires. We took the kind of gold standard measures that are available scientifically and incorporated them into our clinic. Look, I think the major criticism of what we're doing that I hear from people is that it's a very biased group of people. These are people that sought out cannabis treatment. So clearly they obviously believed in it, or were open-minded enough to want to explore it to begin with. And then, as you'd imagine, it's, you can't get everyone to complete a questionnaire, even to begin with, but then to complete questionnaires every 3 months, you need quite motivated patients to do that. So that we are self-selecting a group of people who are really into this, and really feel the benefit from it. And I think that that's probably the major criticism of the data we've got from a scientific standpoint. And look, I accept that, and I think my colleagues in academic medicine, I think it would be really good to be able to do more clinical trials, with cannabis, where we give people placebos and we measure these things in a more reliable, controlled environment. But I think from the point of view of what we're doing as a clinic, we're doing the best we can to monitor how our patients are doing and contribute a little bit to the evidence base behind all of this.
I guess on the flip side of that, though, the demand, the sheer number of people that are interested, to me, speaks volumes about the space. It doesn't feel fringe anymore to me. It might still technically be considered that, at least in Australia, but it definitely doesn't seem to have the same level of stigma or taboo that cannabis once did. In the medical circles, it's still kind of on its way out, but I think especially the recreational side, when you think about North America and that influence across the globe, especially in the West, it just seems to be something that is becoming less and less of a big deal, if that makes sense.
Yeah, I think you're right. I think from the kind of medical perspective, I think we're seeing increased numbers of patients being prescribed this all the time. We're seeing increasing number of doctors kind of moving into this space. I still think in terms of GPs, it's only about 5% of general practitioners who've got any prescribing experience. And look, I still think we're not completely there. I found it pretty difficult to, when I set up Cann I Help, one of the things I set up to do was to rent some space within a GP surgery where I could see patients face to face, because I'm a big believer in seeing patients in the flesh where you can, rather than doing everything purely by telehealth. And it was quite difficult to find space to rent. I'd approach practices and I'd say, look, I'm looking to rent some space, and they say, oh yeah, that should be fine. We've got a spare room on whatever day of the week it was, and then then they come back to you and say, yeah, sorry, we can't have you. And I think a lot of it was the worries about it being a cannabis clinic and about attracting patients that would be disruptive to the general running of the surgery and things like that. So I think there is a little bit of stigma there, and still a little bit of prejudice within the profession. But I think it's we're seeing we're moving quite a lot in the right direction there.
So what would be your message to a doctor thinking about moving to the space, or not sure, on the fence, or how would you, not that you're trying to, but convince a doctor to get into the space?
Are you suggesting Laurence is a sort of a gateway doctor?
Gateway doctor. Yeah, that's what I am. Well, can he help?
Yeah, look, I mean, that's quite a lot of what we do, to be honest. I talk to a lot of doctors all the time. We give educational talks. I share some of the data. But I think often the best thing for a doctor is, if they're not sure about it, then why not? If they're not sure about doing it themselves, then why not follow the path that I did? Refer them to begin with to a doctor that does know about it, but then follow them up and see the benefit for yourself. And that's what convinced me to move into the space. I sent 2 or 3 patients to patients that I've been making very little progress with. I sent them to a medicinal cannabis clinic, and I followed them up myself, and I observed the improvement, and that was what convinced me. And I think that I think you go on a journey as a doctor there, from not knowing anything about it to maybe being something you're a little bit skeptical of. I think often it's a big leap to go from that position of being quite skeptical into actively prescribing it yourself. And I think actually that's where clinics like ours fit in. You can pass the patient to us. We will assess them very, very thoroughly. We will prescribe for them appropriately. We will monitor them, but we'll involve you in the care as well. We'll let you know what we're doing, and we're very happy to liaise with you, and you can see the results for yourself. And then I think often that's probably the best way to get doctors to think, well, maybe I should be getting a bit more involved with this.
And what are your kind of product tendencies? Not obviously labeling any brands or anything like that, but the types of products, or the combinations that you like to put together. Is there, I heard you speaking about the plan that you would propose to the TGA for that specific patient might involve several different cannabis treatments. How does that usually look from your side?
Like it's really, really individualized, and it depends on the symptoms the patient's having. It depends a lot on their previous cannabis experience. So I'm not somebody that follows a recipe with everyone. I don't insist on starting on a CBD oil and then moving up to a THC oil and then introducing a flower. If somebody I feel needs a THC flower straight away, we go straight in with that. So the treatment plans I put together are very, very individualized to what that patient needs. I think generally, I guess there's a few rules of thumb. I like people to be on balanced products where possible. So if they're I like them to be having both CBD and THC within their treatment regime, because I think that the two of them work well together. Often the combination reduces the side effects and increases the therapeutic benefit. So I do like to go for kind of balanced regimes wherever possible. But in terms of the products I go for and the routes that we go for and how we put it together, it's it really it's very kind of bespoke to to the needs of that patient, and whether they drive, what they do for a job, but when abouts in the day their symptoms the worse, and like that's what I enjoy about it as a doctor. It's not this is your standard dose, take one of these 3 times a day. It's very, very much more nuanced and personalized than that, and really working in partnership with your patient. And I think that's a lovely way to practice medicine. And I think I get a lot of professional satisfaction just sitting down with patients and having these discussions and working out plans together.
Does sound very nice, actually. I'm just curious, thinking about the subjective thing we were talking about before, where pain and sleep and anxiety are somewhat subjective. What about conditions that are potentially less subjective, say neurological disorders, things like that, where you can actually see whether somebody has, say, Parkinson's and is in the middle of shaking versus not. I mean, surely that's a little bit more visceral. You can kind of see that, in the flesh, if that makes sense. Does that have a different impact? Do you see that? Is that something you come across?
Yeah, I think there are certainly objective things you can observe about patients on treatment. So you're right, with Parkinson's, you may see a reduce in the stiffness, a reduce in, that their muscles and their body maybe overcome some of that rigidity, and that's something that you can detect when you examine a patient as well. But even treating patients with chronic pain problems, sometimes you just see them walk into the consult room, and they're less stiff than they were before, and they're walking, or the limp that they've had has improved and their mobility has improved. So, look, I think with all of these things, although we're often getting the patients to report on their subjective experience of things, there's a lot of stuff that you can, that you can observe from a clinical perspective, as well when you examine patients. So, look, I think you're right. Diseases, neurological diseases, particularly things like Parkinson's and stuff, and epilepsy as well. You can measure seizure frequency usually very reliably, because a seizure is normally a fairly clinically evident event. So there are things you can measure in a slightly more exact way. But yeah, I kind of also feel that the patient's lived experience of everything is just as important as that. And I think I guess we have a tendency in medicine and science generally to prefer stuff that we can really objectively measure, because it just makes the research easier. And I think that there's arguments for that, but the mantra I've always followed, and what I was always taught at medical school is, measure what you value rather than value what you measure. And if quality of life is the main thing that you're valuing, then come and find a way to try and measure that, rather than measuring a biomarker which you can measure really accurately, but may be of little clinical importance to the patient. So yeah,
that's great, Laurence. I've heard it described, even just, people who get something out of medical cannabis just describe even just having like more positive interactions with their family, and the little things like that obviously can't be objectively measured, but that just a whole quality of life improvement. I've got one last question for you, just since we've got the pleasure of having a doctor on the show. I just wanted to know, in terms of dosing, so for those two common conditions we've been discussing, pain and depression/anxiety, is it usual that, as a GP, that you would sort of tell your patient to take medical cannabis as and when symptoms are at their worst during the day, or is there a more preventative approach that you can speak to from your clinical experience?
So I think this is where the different forms of the medication come in. Okay. So generally with oils and with oral products, we know that they're going to take an hour or two to get to work, and they're going to hang around in the system a lot longer. So with oil products, I'm generally someone that would advocate regular dosing for those at specific times of the day, obviously dependent on the patient's lifestyle and what they're doing. For fast-acting products, and particularly, thinking of inhaled flowers there, where you can get a therapeutic effect within a few minutes, they do lend themselves much better to that kind of on-demand dosing for, when the anxiety is particularly bad, or when they're having a PTSD-related flashback, or when the pain suddenly flares up. So I think you've got different products there for different niches within that, and generally, I think that the longer acting ones lend themselves more towards kind of regular preventative dosing, and that the fast acting things, and particularly the inhaled flowers, are much more useful as that kind of on demand type product.
No, that's great. Well, we have you've been very generous with your time, because we know how busy you are, Laurence. So thank you so much. And we've just really enjoyed unpacking a bit of this, and hopefully it's of value to our audience as well. But until we speak again, take care.
Thanks very much. Thanks for having me.
Cheers.
Thanks, Laurence.